Hey there, future doctors. Welcome back to the channel. A middle-aged man walks into the emergency room clutching his chest. Is this a heart attack, a lung problem, or just indigestion? In the next few minutes, we must find out, because the right answer can save his life. Today's lecture focuses on chest discomfort, understanding its causes, clinical approach, and the critical steps that guide life-saving decisions. Chest discomfort is one of the most frequent reasons patients rush to the emergency department. Approximately 8% of all ED visits in Indian hospitals are related to chest discomfort. Yet here's a striking insight. Less than 15% of these patients are eventually diagnosed with an acute coronary syndrome that includes heart attacks like STEMI or NSTEMI. In other words, most chest pain presentations in the ER are not heart attacks, but because the few that are could be life-threatening, we must act decisively each time. To simplify our thinking, I like to put chest discomfort into three big buckets. Number 1, myocardial ischemia. Number 2, other cardiopulmonary causes. And number 3, non-cardiopulmonary causes. Let's start with myocardial ischemia, the classic angina or heart attack. Here, the problem is an imbalance between oxygen supply and demand in the heart muscle. If that mismatch is severe and lasts more than 20 minutes, permanent damage begins. That's myocardial infarction. Stable angina is predictable and relieved by rest. Unstable angina happens even at rest or with less effort than before. And if there's actual muscle death, we call it NSTEMI or STEMI, depending on the ECG changes. Now let's look beyond the heart at other cardiopulmonary causes of chest discomfort. Pericarditis, the pain is sharp, pleuritic, and characteristically relieved by sitting up and leaning forward. A unique clue is radiation to the trapezius ridge due to phrenic nerve involvement. Aortic dissection, here the pain is tearing, sudden, and severe. If both ascending and descending aorta are involved, it moves from the anterior chest to the back. Risk factors include hypertension, Marfan syndrome, and even pregnancy. Complications can be deadly: myocardial infarction, acute aortic regurgitation, or cardiac tamponade. Pulmonary embolism, the presentation can vary. Small emboli cause lateral pleuritic pain, while massive emboli produce central chest heaviness, hypotension, even syncope. Sudden breathlessness, pleuritic pain, and tachycardia should always raise suspicion. Pneumothorax, this is sudden pleuritic pain with decreased breath sounds on one side. If it progresses to tension pneumothorax, that's an absolute emergency. Immediate decompression is life-saving. Now let's move to the third bucket, the non-cardiopulmonary causes of chest discomfort. Gastroesophageal reflux disease. This produces a burning pain, often after meals, worse when lying down and typically relieved by antacids. Esophageal spasm. Here, the pain can mimic angina so closely that it's sometimes indistinguishable, but it may be relieved by sublingual nitroglycerin, just like true angina. Gallbladder disease, especially gallstones, can present with pain in the right upper quadrant, radiating to the back or scapula. Many times it gets mistaken for heart pain. Musculoskeletal pain. This one is usually localized with tenderness over the chest wall, and importantly, it's reproducible with palpation. Herpes zoster classically produces a burning dermatomal pain that appears even before the rash develops. a key trap for clinicians. And finally, panic attacks. These often cause chest tightness, a sensation of breathlessness, and that classic overwhelming feeling of impending doom. Now that we've looked at the different causes, let's put it all together. How do we approach a patient with chest discomfort in real life? The main goal is simple but critical. Rapidly detect the life-threatening causes first. These include acute coronary syndrome. Look for prolonged pressure like chest pain, radiation and diaphoresis, aortic dissection, tearing pain with a pulse deficit, pulmonary embolism, sudden dyspnea and pleuritic pain, tension pneumothorax, hypotension with tracheal deviation, and cardiac tamponade, hypotension with muffled heart sounds. Now let's go step by step. Step 1 is history. Always begin by characterizing the pain, its quality, location, radiation, pattern, and what triggers or relieves it. Ask for associated symptoms like dyspnea, syncope, or nausea. Step 2 is examination. Look at the general appearance. Is the patient in distress, sweating, or using Levine's sign, that clenched fist over the chest? Check vital signs for hypotension, tachycardia, or hypoxia. On cardiac exam, listen carefully for murmurs, rubs, or gallops. On lung exam, look for rales or absent breath sounds. And don't forget the abdomen. Tenderness may point toward a gastrointestinal cause. Step 3 is investigations. The most urgent is the ECG. It must be obtained within 10 minutes in the emergency department and repeated serially if needed. Cardiac troponin testing, ideally using high-sensitivity assays, is next. Chest X-ray may reveal pneumonia, pneumothorax, or even a widened mediastinum. And finally, use targeted tests as indicated: D-dimer, BNP, echocardiography, or CT angiography depending on the suspected diagnosis. Now, once we've gathered history, examination, and initial investigations, the next step is to stratify risk. This is where structured decision support tools are extremely useful. One of the most widely used is the HEART score, which stands for history, ECG, age, risk factors, and troponin. It's a simple yet powerful way to identify which patients are low, intermediate, or high risk for major adverse cardiac events. Another tool is EDACS, the Emergency Department Assessment of Chest Pain Score. This score is particularly good at identifying low-risk patients who can be safely discharged from the emergency department. And here's the key. When these scores are combined with accelerated diagnostic protocols and high-sensitivity troponin testing, the miss rate for acute coronary syndrome falls to less than 0.5%. If EDACS is greater than or equal to 16 or ECG/troponin is abnormal, the patient is not low risk and needs further evaluation or admission. So, it is a clinical tool, but it must always be combined with ECG and biomarkers. Finally, let's talk about critical pathways, the structured approach that ensures patients with chest discomfort are managed both safely and efficiently. The first priority is rapid identification of STEMI, because the sooner we open that blocked artery, the more heart muscle we save. Next, we need to identify low-risk patients early, those who can be safely discharged with follow-up rather than being admitted unnecessarily. And equally important, we must avoid unnecessary admissions and tests. Not every chest pain needs an angiogram or prolonged hospital stay. A rational, pathway-driven approach ensures the right care for the right patient at the right time. This balance, saving lives while reducing waste, is the essence of critical pathways in chest pain management. Now let's shift from the emergency department to the outpatient setting. Here, the overall probability of acute coronary syndrome is lower, but the stakes remain high. The focus should be on a careful history and a resting ECG. If the clinical suspicion of ACS is present, even in a clinic or office environment, the safest step is immediate referral to the emergency department for further evaluation and monitoring. Remember, missing ACS in the outpatient setting can be catastrophic, so when in doubt, refer. Let's now bring everything together in a rapid triage framework for acute chest discomfort. Step 1. Is the patient unstable? If yes, move straight to immediate ECG, resuscitation, and targeted urgent tests. Step 2. Does the ECG show STEMI? If yes, activate the cath lab immediately for reperfusion. Step 3. If there's a high suspicion of ACS but no STEMI, we rely on serial troponins, structured risk stratification using HARD or EDAX, and additional imaging as needed. And finally, if the suspicion for ACS is low, broaden the lens. Consider other life-threatening causes like aortic dissection, pulmonary embolism, or pneumothorax, and also non-cardiac causes like gastrointestinal or musculoskeletal pain. Manage according to the underlying diagnosis. This structured approach ensures that we act fast for the emergencies while avoiding unnecessary interventions in lower-risk patients.